Welcome to the Clinical Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, Limmer Education and ESO, we are able to make science more accessible and understandable.
Thank you all for joining us and welcome to the June 2024 edition of the Pre-Hospital Care Research Forum Journal Club. Special thank you to our sponsors, Limmer Education and ESO, for making this possible. I'm Michael Kudius. I'm joined by Jeff Rollman and Dr. Bill Toon today to discuss a very interesting article that actually we've been kicking back and forth for a couple months now and are thrilled to bring to you, called Assessing Burnout Rates and Contributing Factors in Emergency Medical Service Clinicians. Now, I think one of the best things about this article is that it was published in the Journal of Workplace Behavioral Health. This is probably not a journal many of those of us out there are subscribers to or pay much attention to. It was an interesting article to come across in our PubMed search, and goes to demonstrate that there's lots of EMS articles out there in places that you might not always expect. Jeff, is this a journal that you subscribe to or that you read regularly?
I can't say that I do, but this is something that I'm definitely very happy to see, that these critical EMS issues are not just something that are kept strictly within our profession, but we can share our expertise and talk about these issues with others.
Absolutely. I couldn't agree more. And I did just throw the article into the chat. So those of you, it is behind a paywall. So those of you that are on today can see the whole PDF copy of it. So there. So interesting article to start us off. I think sort of going into this, we sort of all have our assumptions about burnout, but certainly an opportunity for us to evaluate the research and really see what it means. As a reminder, the discussion is paired with an article written in EMS World called Journal Watch. We encourage all of our listeners to check it out. It's at emsworld.com under the category of education and training. As a reminder, listeners can use the chat feature. It's on your screen, and type in questions or comments, and we'll bring those into the conversation as we go. Lots to discuss in this article, so let's dive into it. I thought the best part of the introduction for this article specifically was that they started defining what burnout is and did give us a little bit of a history lesson on where the term burnout came from, noting that 1974 was the first time that we truly started to introduce this concept of burnout. In 1974, when burnout was first introduced, it was defined as becoming exhausted by making excessive demands on energy, strength, and resources. And I thought, gosh, they're defining burnout as sort of exhaustion, which I feel like most of us in EMS probably find ourselves in. But the definition has evolved a bit, and in 2001 the definition arrived that sort of the definition we operate from, the definition that we utilize in most research, which is a phenomenon marked by the trifecta of exhaustion, cynicism, and inefficiency or inefficacy. Jeff, thoughts on that? I just thought I always appreciate when they use the word trifecta in a definition, but I thought that addition of cynicism was really quite interesting when I think of someone who's maybe burnt out or a little salty, if you will. Cynicism is a huge part of that.
Yeah, I definitely think that's an interesting definition, and that was 2001 that I'm thinking that we might be due for some new official definition now. And then what also struck me was 1974 was that first definition. And I'm thinking, that is right around when EMS was getting started, just a few years after the white paper, just a couple of years after the first paramedic pilot programs. Did EMS invent burnout? No.
Bill, this is a great historical context on burnout. Any thoughts, as well as some of the common causes that we see leading to burnout? Any that didn't make the list that surprised you?
No, I can't say anything, but it is a term that I've heard throughout my entire career, is burnout. And the reality is it exists. Even though at times I just would pass it off as someone having a bad attitude instead of realizing that, they're burned out from the work that they're doing. So there's a difference, I think, there between, what I thought at one time and what we have a better understanding of now.
Absolutely. And maybe even the value of giving it a name, right? We have to recognize a problem before we can work to fix it. So, providing some solutions to that. And actually, this paper does a great job, and we'll get into it into discussion of some ways to solve some of these causes of burnout, which I think is really the true meat and potatoes of this study. The authors did do a nice job again of giving us that historical context of burnout in EMS and providing us some previous studies that have indicated burnout occurs 16 to 56% of the time. Lots of research that they cited on some of the different common causes. I don't think it surprises many of us that long hours, high call volumes, low compensation, and low managerial support are some of the leading causes of burnout. Some that I didn't necessarily think of, but the authors noted that I thought were important were physical and emotional trauma and the processing time for that trauma, which is incredibly important, but oftentimes it's the pediatric cardiac arrest call and then right into the fall patient, and there's really no time to sort of put it in its place and really contextualize that trauma. A couple other rapport relationships with other healthcare fields. That wasn't something that necessarily would have come to the top of my list, but is cited in the research. And then the stigma associated with assessing mental health in EMS. And I've put that at the top of my list. Jeff, Bill, thoughts on either the list?
Yeah, I think these causes, a lot of them are things that I probably would have brainstormed, that none of these really sounded especially out of the ordinary or particularly unique to EMS. I mean, maybe the call volume just could be high patient load, for example, in hospitals, but that second to last, the poor relationships with other healthcare fields. I know every profession struggles, but I think that is something that is especially unique to us as EMS clinicians, being a fairly new field. I mean, nursing has been around for, I think, almost 200 years, physicians, hundreds of years, and EMS is such a young field. I mean, just over 50 years almost, that really many folks are still trying to understand the role of EMTs and paramedics. And I know that I've definitely had plenty of frustrating times when working with other professions who don't understand what we do as paramedics, what we do as EMS clinicians. So I could definitely see how that's an additional cause potentially of burnout.
Oh, absolutely. And I think as we're seeing more EMS providers work in more healthcare settings, hopefully that helps to sort of introduce those concepts. But you think too what the ramification is on the patient experience as well, is if the hospital or the pre-hospital, doesn't trust the pre-hospital professionals, then they're redoing the assessment and re-asking all the questions. And that only delays the patient experience, treatment, and all of those things. So yeah, a nice little historical context that the authors gave us as they dove through their introduction, which I really can appreciate because I think sometimes we just assume we know what the burnout's out there and that we have ways to fix it. And you're like, it's actually a fairly new topic. In fact, it's sort of just as new as EMS is. So really interesting there. The study question that we're going to explore today that the authors explored is, this study aims to further explore pre-hospital provider burnout by describing the prevalence and associated factors among licensed EMS clinicians currently employed at public and private services in Massachusetts utilizing a validated burnout inventory. So again, adding to the literature for the topic of burnout in EMS providers. And I think the one big key takeaway here, and we'll show it in just a few slides, is utilizing a validated burnout tour. So I think it'd be easy to just ask EMS providers, are you burnt out? But that's probably not going to give us a very accurate response to the true question. There are validated tools out there, and the one that these authors used is really quite interesting, and we'll spend a little bit of time going through it. Jeff, tell us a little bit about their inclusion criteria and the sample size.
Sure.
Before you jump into that, I want to try to demystify or debunk something as it relates to our history. I really do believe that what we know as EMS, that name only really became popular after the white paper. But we do have a history that goes all the way back to 1865, when the first hospital-based ambulance started. And we have a rich history prior to what's known as modern EMS, which started in 1966. But I also want to let you know that was also the time of the birth of the emergency medicine as a discipline within itself. So I think that they're young. Emergency medicine as a discipline, as a recognized board certification, and think even a younger group of that, younger than EMS, are EMS physicians because they only had obtained a board credentialing in a less period of time. While I agree with you, nursing and physicians have a much more extensive one. I really do think EMS has to start embracing its complete history. And I think it's okay to look at it in two parts, as truly the early days and then the post 1966 white paper. But it really did, even after 66, it took a number of years to ramp up to get things happening. So I really think there's an opportunity for us in the future to embrace our history better, because I think it's rich and it's colorful. And there's a lot of things that came out of those early years that we still practice now.
You are absolutely right, Bill, and I thank you for calling that out. I actually went to a history museum last week, and they were talking about ambulance corps during World War I and World War II, that no, they didn't have the title EMT or paramedic, but ambulances were around then. I know during the Civil War, they definitely had quasi kind of ambulances that were pulled by horses. That, yeah, thank you for calling that out. You're right. This field existed, even though it didn't necessarily have the same nomenclature as today.
In essence, EMS predates burnout.
Absolutely. Yes. So diving into our methods. So every study, it's always important that we really understand the setting of where it took place. And this is especially important when we try to interpret some of those results, because we want to know who were the study participants, who were, where are we getting all this information from? And this took place in Massachusetts. So it was a survey of both EMT basics, advanced, and paramedics, all in Massachusetts, and they had several inclusion criteria in order to be included in this study. So had to be at least 18 years old, had to be fluent in English, all the surveys were in English, had to be nationally registered. And I looked this up because I thought, hey, that's going to leave a lot of people out. But Massachusetts actually requires all their EMTs and paramedics to maintain their national registry each time they recertify with their state paramedic or EMT license. So it doesn't really, if you're licensed in Massachusetts, you're going to be nationally registered for the most part. You have to be currently licensed, of course, and then actively providing some sort of clinical care role in EMS. And they did a convenience sample. So they didn't just mass email every single EMS provider within Massachusetts. They chose 16 EMS agencies throughout the state that included both rural, urban, and suburban services. And there was, and they were different types of EMS provider agencies. So one of them was hospital-based, 8 were fire-based, and 7 were private EMS agencies. And they were all recruited either at agency training sessions, continuing education sessions, or via email. We could go to the next slide, please. So this Copenhagen burnout inventory, what was it? So again, as Michael was saying, this isn't something where they just ask EMS clinicians, are you burnt out? I mean, we could all do that, we probably know, but they use this validated scale, which has been cited and used in the literature, both in healthcare settings, as well as outside of healthcare settings as well. So thinking about this journal, Workplace Behavioral Health, many of the readers of this journal have probably seen this Copenhagen burnout inventory, since it's something that has been around for a bit and is pretty well validated and has also been updated with time. I believe this wasn't the first version that was used. They have made some updates with this over time. And there are 3 different subscales, as you could see. So there's personal burnout, and then there's 6 questions relating to that. So things like, how often do you feel tired? How often are you physically exhausted? And then there's work factors, the work burnout. So asking the participants if they feel emotionally exhausted, for example. And then finally, patient, or what was previously called client burnout. So asking how somebody feels when they work with patients, they find it frustrating to work with patients, and they used Likert scales so that so always, often, sometimes, seldom, never, or almost never. So basically 5 different answer choices. And then they made this into a numerical score. And actually, instead of 1 to 5, it was 100, 75, 50, 25, and 0, just in order to keep things standardized. And then the next slide, please. Oh, okay, yeah. So what did they do with all these scores at the end? So they got a final score, and that score can range from 0 to 99. And then there was a cutoff, which is also validated. So 1 to 49 are those on the low end, and that's considered low burnout. And then a final score of 50 to 74 is considered moderate. And then 75 to 99 is considered high burnout. And if somebody scores 100, then that is severe burnout. And generally we use this cutoff. So a mean score of 50 or above is considered to be burnout. And not to say that somebody who's 49 isn't experiencing any symptoms of burnout, but for the purpose of this study, they just utilize this 50 cutoff point.
Yeah, I think that's important, Jeff. And I think the CBI, or the Copenhagen Burnout Inventory, says that if you're a 50 or above, it's sometimes, and if you're 75 or above, it's often. So I think using that 50 cutoff is a great way to start to say, yes, these patients are sometimes experiencing burnout. So again, for this study, that's sort of what their mark is. That also would sort of equate to an agree or strongly agree to the majority of the questions, which I think is a reasonable expectation to set for this. I did put in the chat if anybody's interested in seeing the burnout scale, the one we copied in here that's specific to patients. There's a link in the chat that'll lead you there. That's open access, so you can get access to it. If you just do a Google search for the Copenhagen Burnout Inventory, there's also some great other articles that are out there on it. So if you're looking to do something like this at your agency, the resources are all open access.
Exactly. And then speaking of open access too, the survey was all done via RedCap, which is something that is also open access and free to use. So they didn't use any fancy software at all. They just approached people at agency trainings or via email, but the survey itself was done anonymously. They didn't collect any identifying information aside from demographics, which we'll talk about. And this took place between September and December of 2021. So just keep that in mind when we talk about our discussion a little later, because maybe some other things were happening at the same time. And this was IRB approved by University of Massachusetts. And then when it came to their actual analysis, this was mostly a descriptive analysis. So it was fairly simple in terms of the methods, but extremely powerful. So just utilizing all that demographic data, all these different questions about individual EMS clinician characteristics, they were able to calculate prevalence ratios. What's the prevalence ratio?
I'm so glad you asked, Jeff. I do think helpful to note the time period. When I was reading this, I was like, ooh, I don't know if you could have picked a more stressful time for EMS providers in terms of the COVID pandemic, right? Sort of early on, it was a bit of a concern, but towards the beginning of flu season, the first year of COVID, I think we all had some reservations about how bad it could get in terms of making sure that everyone got what they needed in terms of medical care. So yes, prevalence ratio. So I did a little bit of reading on this, Jeff. In fact, I asked ChatGPT to explain a prevalence ratio to me as if I were a middle school math student. Because if you had to look at my stats background, that's probably where I fall. And I thought they provided something really interesting here. And my goal is to try and articulate what the difference between a prevalence ratio and an odds ratio, because I feel like a lot of the time we're looking at odds ratios, but that's more of a predictive model than a prevalence ratio, which is sort of in real time. So here's what ChatGPT explained a prevalence ratio as. Imagine you're playing a game with marbles. You have 2 bags of marbles, one with red and one with blue, and then you mix them together. And then you have another bag with only blue marbles. So we've got two bags, one with blue and one with red and blue. Now let's say you want to compare how likely it is to pick a red marble from the mixed bag compared to the bag with only blue marbles. Using a prevalence ratio is like counting how many red marbles there are in the mixed bag compared to the bag with only blue marbles. You directly see how many red marbles there are in one bag compared to the other. But using odds ratios is a bit different. It's like saying for every red marble, how many blue marbles are there? It's not as straightforward as just counting the marbles directly. So prevalence ratio is simpler and easier to understand, especially when you're comparing how common something is in different groups. It's like looking directly at the numbers, while odds ratio is a bit trickier because it involves thinking about the chances of something happening in relation to something else. So I think, to me, this is great. Prevalence ratios are real-time analysis, as opposed to sort of a predictive model of what we think will happen based on this. So instead of saying prevalence ratios based on what I'm reading, I think it's just the prevalence of something occurring. So I appreciate Brooke jumping in the chat as well and agreeing. I stole, Brooke knows this, but I stole this from Jeff Jarvis. He had ChatGPT explain to him some statistical methods as if he were some person with a certain, like someone from the South with a certain background, and it explained like a very interesting way of explaining Bayesian analysis. But so I used ChatGPT to explain it to me like a middle schooler, and I found much success in statistical methodology that way. So in essence, that's what they did. We're going to get to their table of prevalence ratios, but in essence, you can think of a prevalence ratio as the prevalence, and this is really helpful in cohort studies or cross-sectional analysis. So this is a cohort study, it's a group of people, and we're looking at in real time at what the numbers are today. We're not going to go back and sample these people again later on. We're not going to try and come up with a predictive value of later in life something's going to happen. It's the true today. This is what we're looking at. So that's the interesting part of this and why they chose to use prevalence ratios rather than like an odds ratio, for example. So
yes, and those prevalence ratios are still pretty flexible. We can still calculate confidence intervals with them, like we see in many of our other studies. So we can also kind of gauge the significance of each finding. And then just keep in mind that everything that we're going to be looking at in our results, that when we talk about a positive CBI screen or a positive burnout screen, again, it's that 50 cutoff, which means a mean of sometimes reporting these burnout symptoms or greater.
Yep, absolutely. Jeff, do you want to walk us through some of the results, at least the beginning of them?
Sure. So with our results, they had a response rate of 21.4%, and it was 386 who completed their survey, and they were shooting for 384 in order to get their power. So they actually hit their power right on the mark. They must have done something really well. They were able to get the exact number that they needed, essentially. So the sample size, their response rate was a bit lower, but we expect this often with our surveys that we administer. And as far as looking at our patient demographics, Table 1 does a really nice job explaining each of these baseline demographics. We could see that we have folks that are younger, folks that are older, a nice mix, but many of them tend to be around that 25 to 40 year age range. No surprise that EMS clinicians tend to be a bit more male than female. Years of experience, again, a broad range of years of experience, some that are younger in the profession, and whereas others that are more experienced. Service type, though, that is definitely something that stood out a bit. So again, keep in mind this area, this all happened in Massachusetts, and this was a convenience sample, but private EMS was nearly 80%, whereas fire-based EMS was less than 10%. I know in some parts of the country, fire-based EMS might be 100%, or hospital-based might be 100%. So that, setting does definitely affect our interpretation a little bit later, but it might not have been significant. So we'll talk about that later on. And then as far as those that intend to leave EMS, not super surprising, but a lot of people might use EMS as a stepping stone to other careers. So we saw that almost half were already planning to leave EMS. Unfortunately, quite a few reported injuries. So more than half reported some sort of injury within the last year, within the last month, or within the last week. That definitely surprised me a bit. I know that we deal a lot with workplace injuries, unfortunately, but that was higher than I thought. And then as far as hours worked, most folks were working a bit of overtime. So we saw about 40 to 55 hours per week was more than half. Anything else that you wanted to point out?
No, I think the injury thing stood out to me. The private-based ambulance thing, I think, yeah, we'll see how that plays into our results because the authors will stratify for that. The injuries, I seemed recognizing that EMS providers are like at a five-fold increased risk of workplace injuries rather than the general public. I didn't think it would be this high. It'll be interesting to see if there's a burnout association there. But I wasn't expecting an injury within the last year to be almost 50% of the sample size. So that really surprised me. And as a reminder, when I put my educator hat on, to remember that like all those lifting and moving trainings are incredibly important. So just sort of hitting that home in their sample size here in Massachusetts. So no, those were the same things that stood out for me. And here's sort of the beginning of what the CBI told us, what the Copenhagen Burnout Inventory Score was for patients. So dive into it, Jeff.
Sure. So we see that our mean and median are both just under 53. So that means that, again, this positive screen, we see that more than half of our providers who completed this survey, 55.4% of them reported their average CBI score was 50 or greater. So most people were reporting at least sometimes having these symptoms of burnout. And then we saw that 50 to 75, that was definitely much more common, but that much more high burnout rate, 11.7% of the participants reported a average in that 75 or greater. So seeing that, wow, this kind of struck me. I knew that EMS providers were pretty burnt out, but we can see right offhand here that, yeah, these CBI scores are pretty high.
I always ask myself too, does this pass my sniff test? Does looking at this, and do I assume that about 50% of those in EMS are experiencing some level of burnout? And yes, I have to be honest, I thought it would be higher than this. Just reading those questions and knowing the people that I've worked with and around, I thought it would be higher. I guess I'm a little bit happy that only about 11% are in that severe burnout category. That's at least, fixable, or like at least we can work with those people. I know we'll get into it a little bit more, but I guess I thought it would be slightly higher than that. I thought we'd seeing 2/3 of our people being in some level of burnout or greater. So I guess it's nice to know that only about half of the people are experiencing burnout at any given time. So I'm also interested, as we get into the discussion, what maybe Massachusetts is doing something better to help prevent this burnout. So I guess I was happy that it was only 50% because I was expecting something more drastic.
Yeah, I guess it depends on how you look at it in your perspective.
So here, Jeff, are the contributing factors to burnout. So these were polled so all the participants, as part of their survey, were asked what was contributing to their burnout, and they had to choose, they had a Likert scale, so they could choose what factors were or were not leading to their burnout. And I thought the left column was probably the one that meant the most to me. These were the people that had the burnout, right? Or sometimes or always had burnout. So that CBI scale of greater than 50. So these were sort of the top 3 or 4 things that caused them their burnout. And they said inadequate compensation. I'm not surprised to see inadequate compensation at the top of that list. And then followed by high call volume, inadequate breaks between calls, and then inadequate managerial support. I guess I wasn't too shocked to see any of these. Just based on what I hear people complaining about in EMS. I don't know if you had any additional thoughts.
Yeah, I mean, I would say that just looking at both columns, so the positive screen and the negative screen for CBI of 50 or greater, seeing that inadequate compensation, for example, almost everyone was either agreeing or strongly agreeing that that inadequate compensation was a major issue for them. Similar to high call volume, we see some differences, but we know that basically everyone who's responding agrees that these are issues regardless of sort of that burnout level, even amongst those who had lower symptoms of burnout. So I thought it was interesting just to look at the scale of these issues. We know that these are definitely issues, but across the entire population, definitely seeing that these are issues throughout. But I was a little bit surprised, I guess, at the later on. I thought things like physical and emotional abuse among coworkers, I thought that would be a bit higher. I guess maybe I've seen or heard of workplaces where these have been issues, and not to say that it doesn't exist. Plenty of folks still report those as contributing factors, but those were a bit lower than I had expected.
Yeah, it's not the same thing. Physical abuse by patient and emotional abuse by patient was down there too. And I sort of think of, we do a lot in terms of continuing to diffuse and de-escalate situations with patients to prevent those kinds of things. Maybe that means the training is working and they're just not seeing a lot of it. I feel like that's maybe a little bit different than my lived experience, but I'm happy to hear that that's down at the bottom. I thought some other things, I always try and think, my mindset is always solution driven, in that I always sometimes ask people when they come, I'm like, is this just a venting conversation, or am I trying to help you solve this problem? So when I look at this data table, I think like, okay, well, are there some things in here that are easy to solve? Inadequate compensation is an incredibly difficult thing to try and solve when we talk about reimbursement rates and all that stuff. But there are some ones that are probably a little bit easier to solve. And I think some of those things like inadequate feedback or lack of gratitude, that to a manager standpoint, that seems like something that we can work harder to try and fix, whether it's weekly or monthly one-on-one conversations or annual performance evals. It makes me think connecting hospital data with EMS data to provide health data feedback is all really important. A couple of the others that I thought were interesting were inadequate peer support. That seems like another one where we have tons of resources where we can do critical incident stress management, and we can put teams together that really work hard to do that. So I thought from that standpoint, like, oh gosh, that's still being reported as almost 50% overall, but 60% in those that are most burnt out. Some of those things are the things that we can see people working up. I thought also exposure potential was 71% of those that are extremely burnt out. And again, we go back to our time period. This was really at the height of COVID. So that doesn't surprise me. It'd be interesting if you repeated this study with a new group of people, or even at the same group of people, it sort of changes the study from a cross-sectional analysis. But it'd be interesting to see if that goes down when you don't live in the middle of sort of the fear of COVID at the time. So there's still certainly plenty of exposure potentials, but that would seem like it'd be less likely today than any other time. So I don't know.
Yeah, and they were very good questions that they asked about. We're talking about potentials too. So physical injury potential, not just have you been injured, but the potential of physical injury. I thought was interesting too, that they were gauging all these potential factors.
Absolutely. Table 4 gets us into the burnout associated factors, and this is where they start to use their prevalence ratios. So you might look at this table and see, again, these are going to follow very closely how people ranked things to begin with. Again, if more people rank something as a reason that it leads to burnout, that means its prevalence is higher. So if you look at something like inadequate compensation, which is the top of the list, it says the prevalence ratio is 5.8. You might think of that as the prevalence of this occurring is 5 times higher in those who are most burnt out compared to the group of people that took the survey. So those with a CBI of greater than 50 felt that inadequate compensation was 5 times more prevalent. So maybe they reported it being more prevalent than necessarily felt that it was prevalent, though I think probably both are true. So that's sort of how you can look at these. All of these were statistically significant in terms of running their analysis on it. But again, we see very similar information here. Inadequate compensation was at the top of the list. Inadequate time to process trauma, which we didn't see in the last one. High call volume, inadequate managerial support, and verbal abuse from the patient. I sort of hinted at it at the beginning, but this inadequate time to process trauma, I think, is huge. And again, as I sort of think about, okay, how do we work to reduce burnout in our agencies? This seems like a low-hanging fruit where if we have to give our providers, our EMTs, and our paramedics the opportunity to take a time out. We do this in flight all the time, in aeromedical resources. We do this all the time where everyone has to be in to go on the flight, and all it takes is one person out to not go on the flight. Where to give our providers the opportunity, it can't just be, okay, we've coded so many responses in our EPCR, and we get a flag when it's a pediatric cardiac arrest, for example, and we're going to pull those crews out. I think we have to recognize that we don't always know what trauma triggers someone, and thus we have to recognize that it's that individual provider stepping up and saying something. So I don't know, those were a couple of things that stood out for me in this table. Bill or Jeff, anything that you noted?
I guess just looking at these factors and thinking about what can we do with this? I mean, some of these things, unfortunately, like inadequate compensation, not going to change overnight. High call volume, not going to change overnight. But this inadequate time to process trauma, as you were just discussing, that's a major factor here that we see. Number two, I mean, it's not quite at that 5.8, that's 2.88, but that is something that I think that can potentially be changed relatively easy than finding these more difficult calls that might not be obvious. I don't know, maybe severe pediatric patients, severe traumas, certain types of emergencies, and trying to identify these. Since you can't cut out all these calls, you can't cut call volume and down. You can't cut call volume in half. But if we can find some of these opportunities to potentially process trauma, that is something that could potentially be actionable. And then also inadequate managerial support. That is not one that surprised me at all, but that's also something too that I think can be relatively actionable. I mean, that money tree, unfortunately, we can't just fix that, shake that money tree and get that inadequate compensation. We know that's a huge deal that contributes to these factors, but there definitely are some things on here that are actionable, which I like to see.
I thought too, I always think like, how can technology help us on a few of these? The inadequate breaks between calls. I'm sure some of that is because we're doing the documentation right after the call, where as we continue to talk machine learning and artificial intelligence, how does that help us reduce the amount of time needed between calls? Not that I want to necessarily mean that you spin back up to a call, but certainly if you are done with your charting, that probably allows you the opportunity to take the next call. So, Bill, any thoughts?
So many thoughts. So a couple of things in context to our listeners. I think it's important to understand, and we brought it out at the beginning, and I'm sure we'll talk about the limitations. This is a very geographically oriented study, and at the time that it was done reflected how they are, but there's probably nothing that I haven't heard before since the beginning of my career. And there are things, though, I think it's going to require does the leadership of the organization recognizes that there are a problem, and do they want to put meaningful solutions into correcting it? What are the educational components that could be done to make sure people understand and have the resources available to them? Is there a peer support program in there? Does the agency feel like a meat grinder, or does the agency feel more like, hey, this is a place I want to work, and I want to work for a long time? And, as you said, there's quote things that we can do, but people don't want anything that's also disingenuous. We can tell through, we said the sniff test, we can tell when, someone is blowing things at us and they're totally meaningless. Certainly, I know I've been guilty of doing that to people that I've supervised. And, luckily at some point they told me that, or I realized on my own. I can't say I ever became the best artful person out of it. But I look at for things like call volume. You're absolutely correct. Call volume is not us, but doesn't the agency, okay, we know this is a peak time, we need to bring more units on. Well, then that becomes a budget type thing. I mean, it's not a simple thing that exists here, but if we can, if the organization has the willingness to do it, can make the changes. And that's, I think leadership's important. And I think if we ask these people more about it, you've heard the saying before, people don't quit the job, they quit the leadership or the management, whatever term that you want to use to describe them. But I do like this. I would love to see this
ramped across the country, even if it was done by NASEMSO regions, and to again drive the right amount of numbers to really understand. And this would probably be something that would even need to be done, every 3 to 5 years or something like that, or to find out, are we making an impact? Are we causing a change? Have we developed what's necessary to help people be better? Because I would love people to stay in the profession. I would love them not to see this as a stepping stone, because I'm glad for them personally, but I'm sad for the organization, because we lose, wonderful brain drain when that happens. But for that individual to go on to become something in nursing, or whether it becomes something, become a physician, the PA, and then sometimes we get them to circle back and help EMS. But I think I would like to see more people make this a true career, and fire-based agencies that are part of a real retirement plan are able to do that for their firefighters, but they're not able to do that for their civilian employees within a fire department. They don't fit into that. I was very fortunate in my position when I worked in Kansas, and this is throughout the state. It's called the Kansas Police and Fire Retirement System, and every EMS agency, at least county agency, or government agency, was a part of that. So I retired with a retirement plan equivalent to my brothers in the fire and the police. And that makes a big difference, that, sometimes you are willing to work longer because you knew there was a pot of gold at the end of the rainbow, so to say. So I think we have a lot of work to do. I think we can't stop with this. I think this is a great hypothesis generating thing. Is there a way to make this better? Is there a way to make it cyclical, repeat itself? And is there a benefit for even longitudinal that could come out of this? And the other thing is, I wonder, what would it be like if we gave this at the very beginning of an EMT course versus or paramedic course, and then at the end, and that's somewhere at a year after they've been in the field and stuff? It'd be very fascinating to see, do they develop these, by where they go to work, or the kinds of agencies. But as I said, I could easily ramble on, looking back over my time, but I know we have a little bit more still to cover here and stuff. But I think I really have enjoyed this and the discussion. But I think I just want to let you know, I've heard all of this for the last 48 some odd years in EMS. It's not new to me.
Though spot on, Bill, and I think good research always makes us ask more questions. And I'd love to, I think stratifying it geographically, stratifying it via agency would be huge. I had not thought about doing a longitudinal study where we ask people at the beginning of their career versus at the end of, or a year into their career. But it'd be very interesting to see that. It'd also be interesting as you speak about longitudinal studies, like, does your probationary period have an impact on your burnout, right? If you're in a department where you're also the one having to run the calls, but cook the dinner and do the dishes, does that add to your level of stress, comparatively speaking? So just some thoughts as well. And then the authors did provide a couple of results that I thought were sort of some of the key takeaways that came out of our tables, and that there was no significant difference between burnout rates of different EMS service types. So Jeff had alluded to this survey, the sample size was very heavy on the private side. When they stratified for that and did their analysis, burnout was sort of equivalent across all of the different agencies, not one to the other. So important that they did that stratification for us based on their sample size. Between burnout rates, between participants and different numbers of hours worked weekly, there was also no statistical significance. So I think that's really interesting too. The number of hours they saw that each provider was working didn't have a huge impact. If you had asked me before I read this, would that make a difference? I would think that the people that work the most probably have the highest rate of burnout, though that's not what this study found. And I think that's worth noting as we look to solutions about what we do in the future. It's not, it's more the high call volumes and the compensation, not necessarily how long they're working. And to Bill's point, maybe if people are willing to work a little bit more if they know that there's a benefit to it, that light at the end of the tunnel per se. there was not a significant, or there was a non-significant trend towards EMS personnel with greater experience being more likely to experience burnout. So just working longer doesn't necessarily make you more prone to burnout. And I think that's huge. I think this goes back to role modeling, right? We all have mentors and role models in the field of EMS, and we probably look towards the people that drove us to our passion of providing great patient care. And we all can probably recognize in our careers there were some of those folks that were a little saltier, that we probably didn't drive us towards our passion area. So just being more experienced in EMS does not lead to burnout, which I think brings up all kinds of other questions about, again, burnout in those just joining the workforce versus those that are in it for a longer time period. This survey would be prevalent in all of those people, so worth asking. One of the things that did prove some statistical significance in those reporting burnout were history of physical injury. And again, when we look back to this sample size and say that almost 50% or more than 50% of people had an injury within the last year, those are people that are more likely to be suffering from burnout than people that don't have an injury. To me, that's a huge finding, and that at least helps me go find folks that I know are at risk of burnout and start saying, okay, what are we doing to support those members of our community? What are we doing to support those members of our departments so that they're not getting close to burnout, recognizing that an injury adds all kinds of additional stress. How do we prevent that? Jeff, any thoughts based on some of these key takeaways?
Yeah, I was definitely surprised by the age. They had also remarked about how participant age was not associated with burnout, and they found universally high burnout rates in participants of all ages. And I thought that this was something, oh, we get, bright-eyed, wide-eyed, springtail, bushy-tail little EMTs that are young and fresh out of school and feeling, like they can take everything on. And that's actually not quite the case. That I feel like maybe that may have been my experience in hindsight, but maybe not. I'm not quite sure way back when. And it's something, and then recognizing such high rates of folks who are already intending to leave the field, this is not surprising at all that as we deal with a workforce issues, we know that there isn't necessarily a shortage of EMS clinicians, but there's a shortage and maldistribution of how these EMS clinicians are staffed around the country. And there are a ton of EMS clinicians that are not working, that maybe have a license or had their national registry for a couple of years and did not keep that up. So we know that this is something that we really struggle with a career attrition. And this is something that this burnout issue, if this isn't fixed, I mean, there's some things that are easier to fix than others, but if this isn't fixed, that problem is not going to be going away anytime soon. So I think this is yet another wake-up call. And then in terms of what we do, I mean, thinking about our next steps here, I'm thinking one of my passions is very much public health and community paramedicine. And I think this is definitely provides greater evidence, or not necessarily evidence, this provides greater impetus for the need of community paramedics to maybe help reduce some of our frequent flyers, to help deal with our very high call volume, and also provide another opportunity for folks who maybe are experiencing very high rates of burnout from 911 calls or from issues with physical injury. Community paramedics often aren't lifting up patients as much, the same as 911 paramedics. So I think this is definitely shows that maybe using those mobile integrated health community paramedics can potentially help somewhat with this burnout. So that's what I was thinking of.
I think that's huge. And I think while the data is not necessarily out there to say there's less physical violence on a mobile integrated healthcare side, but I certainly think there's probably more appreciation of patients. So the patient may not be outwardly expressing it, but if you can recognize that this is a patient that, was calling 911 once a week or several times a week, and now all of a sudden they're not doing that intrinsic value to helping the system, probably brings some motivation to the provider, but fixes several of the things on the other side for those that are causing burnout in terms of high call volume, lack of time between calls, you sort of reduce some of those things. So yeah, I hadn't necessarily thought about the impact there on mobile integrated health, but certainly provides that opportunity, and again, motivates people to actually sort of continue into the field. While it may not necessarily be additional education, it's probably some additional training in order to do then carry that out, those services out. So really interesting. The authors did a great job in this paper actually providing some other opportunities for where they see this working. I also thought it was interesting, sort of suggesting that some other like agencies do surveys about what other agencies are doing. So again, this is of these surveys, and they did not stratify by agency. But if you know there's agencies that, just surveying other agencies, and what are you doing to support your employees, right? Well, it was EMS week, so we bought in a food truck and a coffee truck and an ice cream truck. Okay, those are great. Does it lead to a reduce in burnout because people feel supported, or is it we have a weekly one-on-one where we sit down and we do call medical director review of calls, right? What is it that the employee really is seeing as the intrinsic value that's reducing reducing the thought that they're not supported. So I thought that was really interesting too, to start asking agencies, like, what are you truly doing to make people feel happy? I think in healthcare, we sort of see this as, I call this the pizza party phenomenon. As a manager, we're like, we brought you pizza. How happy must you now be because we brought you food? But when I was working in the hospital and in EMS and people brought you pizza, it was sort of like, I think much more today than it ever has been in the past, seen as sort of like degrading, of like, we're working our butts off, but all you brought us was pizza. I'm a big fan of free food. So if you do anything to support me and it's food related, I'm pretty happy. But I think that brings up that concept of, okay, so you want more managerial support. What does that look like? You want more time between calls. What does that truly look like? And we really need to start asking other agencies and providers what that looks like. And that was something interesting that they noted in the study that I thought was probably, oh yeah, we should probably find out what that is as opposed to operating off my assumption. Bill, what do you think?
So there are, if you, for example, you touched on some things again that are very clear to my heart. I was fortunate enough to work in a system when I was in Kansas where if there was a whole bunch of units at one hospital, it wasn't unusual for the support services division, which did deliveries throughout the county. They'd swing into that hospital and immediately help the crews put their vehicle back together. So imagine if you have a big system, and there's one hospital they predominantly utilize. Why isn't there a support services technician there and a stock of supplies, someone who can actually help the crews turn around to get cleaned up and give them a little bit of that downtime while someone takes care of the vehicle? Or if it's a transport agency, one organization I know had a patient care transporter, and what they were an EMT that they had a stretcher, and they could actually go up to the floor with the stretcher, get all the paperwork together, double check it and everything, and knew exactly when the crew would arrive. The crew would come up, they would have left their stretcher downstairs, and they come up and get the patient, and it's a quick orderly transfer, and out the door they go. And again, they did it not at every hospital, but they did it at their high volume facilities. There's a lot of creative ways out there, but the thing is are people willing to make the investment? We sometimes are, what's the old saying, something a pound foolish or whatever. I don't remember it, but we sometimes fail to realize that if we can do something to take off that burden from the person during the course of the day, that makes it meaningful. And you said about the snacks. As a matter of fact, we just came out of one of the least meaningful weeks in the world, as far as I'm concerned, and that's EMS week. And because early in my career, I thought it was great, and now I look at it and says you're not even putting a Band-Aid on the major problem that exists. And you should be, this should be every day. This shouldn't be just a week. And, I'm a little jaded maybe, but I think there's plenty of unique opportunities for us to do something. And one thing that jumps to my mind is that, I haven't seen it in a few years, but I know that there used to be a thing published about the busiest fire truck in the country or the busiest ambulance in the country and everything. And I looked at that and says, why would you be proud of being the busiest? Yep. What does that mean? There's not enough resources if you're that busy that you can't even, get a break. Someone says in a 24-hour shift, they ran 24 calls. That's a poorly designed system. To me, that's not a great system. And I hear of places going to 48-hour shifts, and I have concerns about that, but I know why people think it's great, from a provider point of view or the employee point of view, but I see some other issues with that, but I have to be maybe proven wrong by statistics. But yeah, there's a lot of work, but the authors were great.
It'd be interesting to do this study though and look at people that are on different schedules and say, like, I agree with you, Bill. I see all the reasons why people want them, but that doesn't necessarily mean they're good for you, right? If I could eat chocolate cake for every dessert after dinner, I would love to. That doesn't necessarily mean I'm not gonna, have all kinds of health ramifications from it. So I think there's probably some value in doing a survey that looks at that. I also think what level, if you are running more than 24 calls in a 24-hour period or more than one call per hour, the level of patient care worries me. If your goal is to just run the call, maybe you're a great busy service and you have great patient care experience. If you're transporting that many patients, you're spending so little time with your patient. It makes me question, are you doing the benchmarks, treating pain on scene, getting the 12 lead EKG in your STEMI patient, or is it just load and go, load and go, load and go? And that data is out there, right? And we know that's the case, that the busier you are, the less likely you are to do those things. So I think to your point, you're right. If you're the busiest ambulance in the country, maybe that looks good on a t-shirt. I'm not sure that would look good to your community.
No, I would agree with that. I think we have wonderful opportunities. This is a great opportunity for us to look at this study. I think it needs to be replicated, and we need to learn more, and then we need to come up with those meaningful solutions to really move this along, because I'd like to stop hearing the same thing that I've heard throughout my career, and I'd like to actually see that meaningful change take place, because the people that are there day in and day out providing the frontline care deserve it, and we should do everything we can to get it to them.
Absolutely. Jeff, any final thoughts before we wrap up for the day?
Hard to follow everything that Bill is always sharing from his many years of experience, and I know that this is a problem that we've had for a while, and I hope to see some improvement, but definitely want to thank the authors for sharing their work, of course. And I really like how they shared all of these tools. They shared the survey. They were using open source software like REDCap and R. So really this can be done, as you were discussing, this can be done in other states, other jurisdictions. This can be repeated. And I really think they gave us all the tools we need to check in on our progress. And they did an excellent job with recommendations for potentially addressing all these items. So I definitely commend the authors on this work, and I'm looking forward to seeing this study repeated and hopefully having somewhat more favorable results in the future.
I think that's a great point. Both Bill and Jeff, and I would only add to it. Jeff said this is incredibly recreatable, and also some of the solutions are provided in this paper. So if you do this at your agency or your area and you get results back that are similar to these, they provided some great opportunities for feedback and review and how this gets fixed, so that we don't just repeat this cycle. So with that, we applaud the authors for their work here. We're incredibly appreciative of the opportunity to share their work. We look forward to seeing many of you at our upcoming educational podcast. That's Friday, June 23rd, 10 a.m., same time, same place. And we're going to be looking at a novel approach to point of care ultrasound curriculum in air critical care personnel. Really interesting survey. And then on Monday, July 8th, we'll have the clinical podcast, same time, same place. And we're reviewing emergency medical service management of bronchospasm in the United States, a cross-sectional analysis and nationwide quality assessment. So really looking at what interventions we use to treat bronchospasms and if we're all doing it or not. So really interesting study. And again, thank you so much for joining us, for the participation. We look forward to seeing you at our upcoming podcasts.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.